some of them were already covered, so if you can just speed up your presentation a little bit, it would be nice.
Yes.
Thank you.
Hi everyone, I'm going to talk about approach-related complications in anterior cervical surgery and how we can avoid those complications as patient plan. Anterior approach to cervical spine was first described by Cloward, Robinson, and Smith in 1950s. This is surgical approach who has been the most common one used for AC, anterior cervical discectomy, carpectomy, and arthroplasty techniques. Due to its minimally invasive nature, cervical approach is associated with low morbidity, convenient to manage subaxial cervical spine, and even upper cervical and cervicothoracic junction pathologies. However, given the critical anatomical structures residing within the neck and that require mobilization for the anterior cervical corridor, one should be careful to prevent potential complications. If any complication does happen, it should be promptly addressed to prevent catastrophic outcomes. Risk attenuation and safety of the approach begins with proper positioning of the patient. As always in the surgery, care must be taken during position to avoid potential complications. Patients are positioned in supine position. All regions of potential peripheral nerve entrapment and pressure points should be padded, as in the figure. The neck is put into a slight hyperextension position by placing a pillow under the shoulders, and the occipital region of the head should rest on a gel or a gel foam. After adequate positioning, the approach for accessing the anterior cervical spine begins with localization under fluoroscopy. In some centers, if present, three-dimensional navigation can be used for this purpose. For 1 to 3 level surgeries, a transverse incision with generous undermining of the platysma muscle is usually sufficient for exposure and can be made in a pre-existing skin crease to facilitate cosmesis. For 4 level fusions or higher, a vertical incision along the middle border of sternocleidomastoid muscle is preferred, like this. Craniocaudal exposure of the medial border of the sternocleidomastoid muscle helps facilitate the corridor. In some cases involving the lower subaxial cervical spine, the omoid muscle needs to be split. The carotid pulse should be identified, and the carotid shield retracted laterally, while the esophagus and trachea are retracted medially using Cloward retractors. The perivertebral fascia is exposed and carefully dissected to expose the anterior cervical spine. Localization with a clamp placed on the longissimus colli or a Casper pin placed into the vertebral body is critical at this point to confirm the level of interest prior to any disruption. Following finding the target level, the longissimus colli muscles are then elevated laterally for exposure of the oncovertebral joints and to provide a shelf for the retractors to sit in. A vertebral artery should be carefully evaluated on preoperative MRI, angiography, and CT angiography. In a former case of ours, we saw a mass lesion on the left side of C4-5 and C5-6 foramina levels. So to be sure if it is a mass lesion or not, we obtained contrast-enhanced MRI and CT angiography. CT angiography depicted is a vertebral artery loop, consecutive vertebral artery loops at both levels. So we made our surgical plans accordingly and sure the patient was protected. So we should obtain MRI angiography or CT angiography before the surgery to be sure about that. Following putting the retractors, when we dissect the longissimus colli muscles, we should be very careful about the recurrent laryngeal nerve. I will talk about it later. Especially on the right side, it has many branches compared to the left side. So while dissecting the longissimus colli, we should be clearly identify localization of the recurrent laryngeal nerve. What are the approach-related complications? We can talk as esophageal injury, neurological injury, vascular injury, hematoma formation, and infection. Dr. Dahlan already talked about esophageal perforation and vertebrate injury, so I will talk about other complications. The major complications of esophageal-related ones, perforation and dysphagia. Dysphagia is the most common complication, actually. It's a benign course, but we should be very careful when it happens because it can be an indirect sign of other major complications. Its incidence ranges between 2 and 8%. It's the most common complication, as I said before, due to causing from the pressure from retractions. Could be an indirect manifestation of recurrent laryngeal nerve injury, esophageal perforation, and hematoma formation. So we should carefully follow those patients. It can happen early in the postoperative period, and up to 50% of the patients, some of them report some degree of discomfort 1 month even after the procedure. Severe dysphagia or aspiration may lead to deficits in oral intake, leading to nutritional deficiency and requirement for enteral means of supplementation. There are various scales developed to closely monitor occurrence and progression of dysphagia following anterior cervical surgery. Some risk factors have been identified as older age, being women, multi-level surgeries, increased operative time, PMP use, and hardware use, especially anterior cervical plating. Some reports report that this arthroplasty is less likely to cause dysphagia than ACDF procedures. There are some reports depicting rare cases with long-lasting significant swallowing dysfunction. Some preventive measures have been disclosed in the literature, such as tracheal exercise before surgery, releasing retractors from time to time during the course of surgery, taking air out of the antetracheal cuff once retractors are placed to pressure 20 mm mercury, perioperative steroid usage as IV or local, but there are some reports depicting fusion failure and even esophageal perforation after local use of steroids, so we should be careful about that. C5 palsy, yes, it's convenient for posterior cervical procedures, but it's also observed in anterior-related surgeries. Its signs and symptoms are knee weakness in the deltoid and biceps muscles after cervical surgery and can be accompanied by sensory deficits and pain in the dermatome of C5. Its etiology is unclear. There are many theories for that. Its incidence is rare. It's at late onset. There are some identified risk factors such as elder age, myelomalacia, especially at the C4-5 level, foraminal stenosis, and spinal cord rotation observed on the CT and MRI. In one study, it said that after CDA procedures, patients who had C5 palsy had actually an average diameter of 2.35 millimeters. It means that it's a less narrow foramen. Currently, there is no standardized treatment for C5 palsy, and some symptoms can resolve spontaneously over time without treatment. Recovery depends on the severity of the deficit, with mild cases resolving within 3 to 8 months. Corticosteroids are occasionally used to help reduce any evolving nerve injury. However, there is no clear evidence on whether steroid use holds any direct benefit in terms of C5 palsy functional recovery. And we are passing to recurrent laryngeal nerve injury. This is an anatomical drawing. It depicts that recurrent laryngeal nerve and superior laryngeal nerve derives from both vagus nerve, but the recurrent laryngeal nerve has a more long way. It goes under the aortic arch and then ascends to the inferior part of the larynx, and it's just in front of us during our surgery. Recurrent laryngeal nerve injury has been reported as a common iatrogenic complication of various neck surgeries, not only SCD, but also thyroidectomy, parathyroidectomy, esophagectomy. Vocal cord paralysis is the main finding, and it can be asymptomatic, but patients might have hoarseness, dysphonia, and dysphagia. It can be caused direct or indirect way. It has been reported that maintenance of endotracheal cuff pressure below 20 mm mercury has also been shown to reduce the incidence of recurrent laryngeal injury rates. This incidence has been reported up to 16% in some case series. Some patients have partial resolution, but most of them completely can resolve. There are some risk factors as revision surgery, right-sided approach. We know that there are extra branching on the right side compared to the left side, so some surgeons prefer taking the approach on the left side, depending on this finding. Horner syndrome, it's very rare because the sympathetic chain just resides lateral to the longissimus colli muscles. So if we go extensive retraction during surgery or far lateral dissection of longissimus colli while dissecting it, we can give harm to them, especially at the levels of C4-5 and C5-6. It's very rare, but if it happens, we can observe it. Just the patient awakens, we can observe the syndrome as pitosis, miosis, and anhidrosis, as you know. Symptoms tend to completely or partially resolve up to 82% of the patients with time, typically between 3 months and 1 year. These are the vascular injury types: vertebral artery, internal carotid artery. They are very catastrophic. Dr. Dahlan talked about vertebral injury. Hematoma, I will more condense on the hematoma formation. It's very bad, could be life-threatening. Why? Because it can obstruct airway and threaten neurological function by spinal cord compression. When the hematoma happens, it appears at the prevertebral space and along the corridor approach in the neck, very rarely in the spinal epidural space for this occurrence. Risk factors are unclear due to its low incidence, multi-level surgeries, and elder age, especially for the epidural location hematomas. Most of the times asymptomatic, but if it's symptomatic, we should be very urgent, very allergent, very immediately intervene with the patient. Retropharyngeal hematoma, what's its symptoms and signs? Next element, dysphonia, severe dysphagia territory. We should emergently re-explorate the surgical field. Airway should be supplied before any imaging obtained. Bleeding sources of retropharyngeal hematoma can be epidural veins, cancellous bone, muscles, small vessels that lie on top of the longissimus column. How to prevent? As we surgeons, we are very meticulous during the opening and during the main phase of surgery, but we should not make it fast during closure. Meticulous hematososis prior to closure is the main way of prevention of it. We can use hemostatic agents in this space around the interbody graft, judicious cauterization of the longissimus column muscle, more push facial muscles, inserting negative pressure drains, especially for ACDF, multi-level ACDF, and corpectomy procedures. Wound infection is very rare. Why? Because the vascularization of this area is very rich. But it's important if we diagnose an infection. Why? Because it's very close to critical structures in the neck, potential for severe inflammation, mass effect from pyogenic abscess formation, and airway compromise. What are the signs and symptoms? The most common one is localized pain at the area of interest at the postoperative first week, fever, wound drainage, and elevation of lab markers. When after stabilization of the patient, an MRI or computed tomography with contrast agent is typically used to identify a collection or deep effusion. How we can manage this case? Evacuation, irrigation, removal of necrotic tissue, examination of any esophageal injury, maybe, as mentioned by Dr. Dahlan also. Targeted IV antibiotics, timely operation for a quick bacteriological diagnosis. Rigid stabilization may be required in some cases, especially posterior cervical, to make it safe. In conclusion, anatomical knowledge of the surgical area is mandatory. Serious anterior cervical approach complications are generally rare and can be treated conservatively in many cases. However, given the critical structures in this region, prompt surgical management is required to prevent airway obstruction, neurological compromise, and death with certain pathologies. With proper surgical planning and risk mitigation strategies, this approach remains one of the primary workhorses in the armamentarium of spine surgeons. Thank you.
Thank you, Murat. Very holistic overview of complications. It was really very nice tips. And, very quick question for you. One of the most frequent complications, as you said, is hematoma formation. So what's your take on leaving a drain or not leaving a drain, and this related with day surgery of cervical spine, anterior cervical spine surgery? What's your impression on this?
Yeah. I'm very afraid of that complication, hematoma formation, because if it happens, sometimes the patient could be lost on the beds in the ward. So after my operations, I'm trying to make the hemostasis well. If one level, if there's no comorbidity of the patient and no history of using any anticoagulant or other therapies, I prefer not to use any drain, but if there is any history of using any anticoagulation treatment before the